Good, good morning, good afternoon, happy Saturday, everyone. My name is Mike Ruggiero, and I am here to walk through our first of our Cannabis Consequences 101 series for ISCPH. I'm happy to start off with Cannabis Hyperemesis syndrome. There you go. Now, a little bit about me. I graduated from Philadelphia College of Pharmacy in 2016. I've worked in independent pharmacy-based settings, provided MTM-based services. Then I worked in major retail chains, and I stumbled into medical marijuana, where I've been for about 2.5 years. I'm certified in both MTM and cannabis. I also am a certified pharmacist through the American Academy of HIV Medicine. I'm the current secretary on the board of directors for ISCPH, and I'll be the incoming vice president on the board of directors for ISCPH. Quick disclaimer, cannabis is for experimental use only. It's not FDA approved. And I am a dispensary pharmacist for Beyond Flow in Philadelphia, Pennsylvania. A few objectives. We want to understand the physiological mechanisms of cannabinoids in the body, describe the pathology of cannabis hyperemesis syndrome, compare the clinical presentation of cannabis hyperemesis syndrome and cyclic vomiting syndrome, and then be able to develop care plans for a patient presenting with CHS. Quick overview, we're going to do just a little bit about endocannabinoid system physiology and cannabinoid types, walk through phytocannabinoid basics, talk a little bit about synthetic cannabinoids, and then use that to set the stage for cannabis hyperemesis syndrome, talk about prevalence and epidemiology, pathology, clinical workup and presentation, and some potential treatments. Now, we have 3 main cannabinoid types. Our first would be the phytocannabinoids. That's in the cannabis sativa plant that we know and love, and the 2 major ones being delta-9 THC and CBD. We have our endogenous cannabinoids, which our body makes to regulate many different processes. The 2 main notable ones being anandamide and 2-arachidonyl glycerol. Then we have our synthetics, which are made in labs. K2 and spice are synthetic mixes. We have HU, JWH, and a whole host of others, more coming out depending on who's making what. Pinaka and Chronic are 2 newer ones. Now, let's talk about the endocannabinoid just really quickly. So cannabinoid receptors are G protein coupled receptors, and they're the most abundant G protein coupled receptor in the brain. We have our major endocannabinoids, which are lipid-based molecules derived from arachidonic acid. Anandamide and 2-AG, they both act as partial agonists at cannabinoid receptors, and they play a major role in regulating or modulating every nerve response. And this is why these are known as the guardians of the nervous system. It's really important to keep in mind throughout this presentation that they play a major role in regulation of fear, stress, anxiety, and pain. And in a patient case where the individual had a mutation in an enzyme that breaks down anandamide specifically, she didn't really experience anxiety and had a really, really high pain tolerance and experience pain. And that's because these play a major role in those processes. They act as retrograde synaptic messengers, and they reverse the normal flow of our action potentials. Now, like I said before, they're retrograde messengers synthesized on demand from the cell membrane. Now, because they're fatty molecules, once they enter the synapse, we need something to carry them. These are fatty acid binding proteins. The molecules themselves are degraded by fatty acid amide hydrolase in the context of anandamide and monoacylglycerol lipase in the context of 2-AG. Our cannabinoid receptor locations, they're found in the CNS as the cannabinoid 1 receptor. Oh, let me just admit somebody. The cannabinoid 1 receptor is primarily found in the CNS, and this is the receptor in which THC binds to create the euphoria. Now, when our natural cannabinoids bind, we do not experience the euphoria, as well as with the synthetics we do. These play a major role in regulating major nerve processes and modulating point by point basis the nerve response, which I'll get to in just a moment. Cannabinoid 2 receptors are found on immune cells, namely B cells and NK cells. Now let's walk through a simple action potential here. So we have our presynaptic neuron. Our action potential is going down. This is a stimulatory stimulus. So glutamate is being released due to calcium entry, which promotes exocytosis. The glutamate will bind to receptors on the postsynaptic cell and promote the message. Now, if that stimulation is too much, what happens is the postsynaptic cell will release endocannabinoids. These endocannabinoids, such as 2-AG or anandamide, will bind to cannabinoid 1 receptors on the presynaptic cell after crossing through the presynaptic cleft, bind there, prevent calcium entry, and prevent exocytosis of glutamate. It effectively pumps the brakes on the nerve response. And this process is known as depolarization-induced suppression of excitation. Now, when we're thinking about stimuli, there's both excitatory and inhibitory. So this can also occur for GABA, excuse me. So when it occurs for GABA, we see depolarization-induced suppression of inhibition. So when we're inhibiting excitation, the net effect is going to be an inhibitory response. But when we inhibit inhibition, we see the net effect of an excitatory response. We have other cannabinoid receptor targets. Now we see what's called agonist trafficking at cannabinoid 1 receptors. That just means depending on the ligand that binds, we'll see different effects. Cannabinoids also bind to serotonin receptors, PPARs, and transient receptor potential channels. I would like to take a moment to focus on the TRP receptors. Now, the TRP receptors allow us to interact with our environment. I'm not sure if you guys seen the Shark Tank, but they have that buttercloth shirt. And when designed for men, when they put them on, they have this cooling effect. And that's because they have mint fibers threaded throughout, which activates TRPM8 and creates this cooling effect. Now, in the context of CHS, I want to really set the stage by focusing on TRPV1 receptors. So TRPV1 receptors, it's where chili binds. And when chili binds, this allows us to feel heat and pain. So when you look at these receptors, we also have other cannabinoids that bind and act on these receptors as well. Now, they were discovered in 1997. They're outwardly rectifying non-selective cation channels. They're expressed in a whole host of tissues, and they're also a major place of research for new drug development. Activation promotes vasodilation, pain, heat, emesis, and seizures. So ultimately, when you're activating the receptor, we're promoting neuronal activation and stimulation. Whereas when we desensitize it, we see the opposite occurring. So when we activate the TRPV1 receptor, we promote emesis, whereas after we desensitize it, we're going to do the opposite. Natural ligands for this receptor includes anandamide, 2-AG, prostaglandins, and histamine. So our endocannabinoids work naturally at these receptors, and phytocannabinoids that work here include CBD, CBDV, and CBG. Now, you might be wondering, well, if CBD, CBDV, and CBG bind to these receptors, why don't I feel heat when I apply a topical CBD cream? That's because when CBD binds, it very rapidly desensitizes the receptor. Now, on the other hand, THC has minimal activity, but it does work at other receptors on the skin. These receptors are often co-expressed with the cannabinoid 1 receptor. Let's talk a little bit about phytocannabinoid basics. Now, I'm just going to really focus on THC and CBD to kind of set the stage. Now, when we look at the molecular structure of THC versus CBD, I'm not going to go too hard on the organic chemistry, but what we see here is they have very similar structure. They have very similar molecular weights, but in THC, we see a cyclic ring here. Now that cyclic ring, when you're talking about flexibility and rotation, it's not going to really want to rotate. Now, when we look at CBD, we see a methyl group and a hydroxyl group interacting via hydrogen bonds. Now, this isn't a full bond. Now, because of this, the whole structure itself can rotate. And this rotation, because it doesn't have a complete ring, really lends itself to the majority of the pharmacological effects of CBD being mainly at non-cannabinoid receptor targets. Let's talk about just a few of THC's receptor targets. Now, it's a moderate partial agonist at the CB1 receptor. Unlike our synthetic cannabinoids made in labs are full agonists. As a result, so we're talking about the cannabinoid 1 receptor, right? It's a G protein coupled receptor. Now, when we're binding to G protein coupled receptors over time, this is going to desensitize them or result in downregulation of the receptors themselves. It's also moderate partial agonist at cannabinoid 2 receptors and is an antagonist at serotonin 5-HT3A receptor. Side effects of THC. Before we even talk about that, we want to keep in mind we're dealing with phytocannabinoids or plant-based medicine. The effects tend to be biphasic, meaning lower doses do one thing, higher doses will do another. So typically lower doses of THC are anxiolytic and reduce anxiety, whereas higher doses of THC promote anxiety and create paranoia. Now, this threshold, this crossing threshold from anxiolysis versus anxiolytic versus creating anxiety is going to be different for every individual, and not everyone will cross that threshold. So when we're talking to patients, it's really important not to assume that. THC also can create elevated heart rate. Lower doses, it helps with nausea and acts as an antiemetic, whereas higher doses, if acutely ingested in high amounts, can promote nausea. We also can see cannabis use disorder as well in patients. Now, like I said, with CBD, it hits a lot of different non-cannabinoid receptor targets. But when we're talking about specifically the cannabinoid 1 receptor, whereas THC will bind to the main active site, CBD will bind to an allosteric site and modulate the effect of activation at that receptor, effectively kind of pumping the brakes on that response. Now, it inhibits anandamide hydrolysis via blocking fatty acid amide hydrolase action. This results in an increased cannabinoid 1 receptor and CB2 receptor activation as a result of that increased levels of anandamide. So our natural cannabinoid is going to bind to those receptors and create that indirect effect. However, I want to highlight that this is a mechanism of action seen only in mice. In humans, anandamide will inhibit reuptake of anandamide via fatty acid binding proteins. So that distinction is really important to note. But as a result, we still see that indirect action at CB1 receptors and CB2 receptors. It's also an agonist at a whole host of transient receptor potential receptors and hits a whole host of serotonin receptors. Side effects of CBD. So it can cause diarrhea. Typically, if it's ingested and a patient experiences diarrhea, I tell them to split the dose. So if they're taking 50 milligrams in the morning, they get upset stomach, take 25 in the morning with food, and then take 25 in the afternoon with food. It can cause headache. Now, again, the effects of these plant-based medicines are biphasic. So lower doses, they tend to be stimulating due to activation of serotonin receptors, and higher doses tend to promote somnolence. This results from activation and then desensitization of TRPV1 receptors. It can curb the negative effects of THC. The maximum single dose given in an individual is 6,000 milligrams. And if we were to use multiple dose Epidiolex in a 77 kilogram individual dosed at 20 mg per kg per day, this will create a total daily dose of 1,500 milligrams. This is usually split into up to 2 to 3 doses. Drug interactions are something that we always want to consider. Now, I'm not going to really harp on this for the purpose of this presentation, but we always want to make sure we're checking for drug interactions when we're combining phytocannabinoids with other medications, always. So with CBD, if you need to look for drug interactions for that, put Epidiolex, the prescription CBD product, into your drug interaction checker and look from there. THC moderately inhibits CYP3A4, but it's primarily a substrate for CYP2C9. And smoke can induce CYP1A2 via polycyclic aromatic hydrocarbons. There's a whole host of other drugs to look out for. I've listed them here for you, as well as some other drug classes to look out for. Now, let's briefly touch on synthetics. Now, what we typically see is harmless herbs that are sprayed with a spray bottle full of synthetic cannabinoids. So there's no real actual dosing involved here. One spray too much can result in severe dysphoria for consumers. Synthetics are Schedule 1 by the DEA, and the effects are variable and unpredictable. We're not dealing with any regulated laboratories here, and because they are synthetics, they're gonna more potently bind to cannabinoid receptors and have up to 10 to 200 times more potent than THC. The synthetic mix of spice is also known as K2 in the United States. Now, the JWH molecule is named after John William Hoffman, who developed it at Clemson University, and HU stands for Hebrew University, in which was synthesized first by Raphael Mechoulam. Ultimately, yes, these work at cannabinoid receptor, but it also slows GI tract motility. Just wanted to briefly talk about just 4 of them really fast. So we can see the mechanism of action. So most of them are powerful CB1 and CB2 receptor agonists. Adverse effects to kind of look out for include shaking, shivering, tachycardia, vomiting, paresthesia, altered mood and perception, excitatory behavior. And all we're doing is slightly altering the molecular structure, as you can see from the two different derivatives I have placed below. Now that we've talked about all this, we've set the stage for talking about cannabis hyperemesis syndrome. Now, prevalence and epidemiology. It was first reported in 2004 in Australia by Allen and colleagues. When looking at different emergency room visits, it went from 2.4 per 100,000 in 2006 to 13.3 per 100,000 in 2013 in the United States. However, it's important that this is a small sample. So we're talking about 24 states for the 2006 number and 30 states for the 2013 number. And this was via the National Emergency Department sample, or NEDS. We have at least 2 deaths associated with CHS. The first was a 27-year-old female with an 8-year history of cannabis use, and she was seen in the emergency room 2 days prior for nausea and vomiting. She deteriorated into ventricular fibrillation. All histology came back normal, and it was determined to be the cause of death was CHS. The other was a 27-year-old male who was reported to be vomiting more than 10 times per day, 5 to 6 days before his death, and he had a history of cyclic vomiting. But ultimately, though, when you're talking about CHS and trying to figure out rates and populations, it's really hard, but it's thought to be primarily in the 20 to 29 year age range. But the main reason we can't really get accurate rates is, one, we need to, as healthcare professionals, be able to recognize this across the board, and we don't have an agreement on diagnostic criteria, as I'm about to get into. Increased potency of products play a major role here, because we're going to then be, remember, we're hitting a G protein coupled receptor here, and more potently, which is going to create dysfunction, as I get to in just a bit. And it's thought to be more common with inhaled products, but that's also need to keep into account the fact that inhaled cannabis is the most common form used for consumption. So it doesn't necessarily rule out edibles. Let's walk through the pathology here. We're going to start with endocannabinoid system dysregulation, and everything's going to pretty much stem from here. So keep this in mind. We're talking about HPA axis dysfunction, sympathetic nervous system activation, which also leads in with norepinephrine. So in general, when we acutely ingest cannabinoids, we can get nausea. So higher doses of cannabinoids in general, such as THC, can promote nausea. But lower doses, we have activation of cannabinoid 1 receptors, which will actually inhibit nausea in the interoceptive insular cortex and the dorsal vagal complex. Now, the higher doses are proemetic, so we see that again with the high potency products. Higher potency methods of consumption, such as concentrates, which are often used with specialized pens or dab rigs, and synthetic cannabinoids, which are full agonists. Now, there's a theory that buildup of THC in lipophilic tissues may be released, but the data on this is pretty weak. But what we ultimately see, though, as a result of chronic consumption of THC with these higher potency products, is this extended activation of the CB1 receptor, which again is a G protein coupled receptor, from long-term exposure of THC, which will cause desensitization and downregulation of the cannabinoid 1 receptor, which causes endocannabinoid system dysfunction. Now, linking back to what we talked about before, the ECS plays a big role in modulating so many different bodily responses. So this is going to have a lot of downstream effects. So we then also see increased Pha and MAGL expression, which is going to lower anandamide and 2-AG levels, which will also have implications. This has been positively associated with years of cannabis use. Now, let's start with the little graphic on the side and talk about the initiation to acute stress. So acute stress exposure rapidly increases corticotropin releasing hormone. This will bind to receptors and rapidly increase active enzymatic activity of fatty acid amide hydrolase. This will then result in reduced tone of anandamide, which will then contribute to activation of the HPA axis as well as stress-related behaviors. Now, think back to what we talked about with anandamide. Higher levels of anandamide are associated with reduced stress and anxiety. So it makes sense that low levels of anandamide are going to result in increased stress. Now we see a delayed release of cortisol, which will stimulate release of 2-AG. Now, cortisol action resulting in release of 2-AG will work in the hypothalamus and reduce glutamate release via depolarization-induced suppression of excitation. This will help reduce the response. Then we will see anandamide release slowly from the hypothalamus in a tonic manner, which will also further promote cessation of stress-related activity. Now, if we have reduced anandamide levels and we have reduced cannabinoid 1 receptor levels as a result of chronic consumption of high-dose THC products, this is going to promote this process to continue. Then on top of that, as a result of having less checks and balances here, we're going to see higher levels of corticotropin releasing hormone levels, which will also inhibit gut motility. The chronic stress can then downregulate the cannabinoid 1 receptor and may upregulate the TRPV1 receptor. Now, this chronic stress response is also going to lead into the sympathetic nervous system. But in general, though, we see acute THC exposure and withdrawal increasing heart rate and blood pressure. So keep that in mind when we were looking at patients here. But the higher doses of CB1 receptor agonism will increase norepinephrine release in the locus coeruleus and then inhibit GABAergic neurons. Now we're increasing norepinephrine. We're promoting a sympathetic nervous system response. Now, this is going to override the parasympathetics. So we're going to stick with fight or flight versus rest and digest. So the digestive tract is also going to be slowed, and we're going to see impairment of digestion, which also may contribute to CHS. Let's talk about TRPV1 receptor upregulation, hypothermia, inhibited gastric motility, mood disorders, and genetic predispositions. In general, when you're talking about TRPV1 receptors and CB1 receptors, with CB1 receptors in the hypothalamus, lower doses tends to promote hyperthermia, whereas higher doses can create hypothermia. This is not just the case with CHS, but also in high dose consumption in general. Now, these are expressed together. As I talked before, the cannabinoid 1 receptor will inhibit neuronal activity, whereas the TRPV1 receptor is activating, will promote neuronal activity. Now, this downregulation of cannabinoid 1 receptor signaling will alter gastric motility. I kind of look at this very analogously to our opioids, right? So with our opioids, we can develop tolerance to the effects, the pain relieving effects of the opioids, but we don't see any changes in the effects of the GI tract, and it will promote constipation no matter what. Same idea here, really. So we're going to see reduced, an increased tolerance to the effect of the euphoria here, but it's not going to necessarily result in increased tolerance to the reduced GI motility, thereby potentially promoting emesis. Now, the chronic stress will also reduce expression of cannabinoid 1 receptors, upregulate TRPV1 receptors, and then on top of that, the anxiety and depression may also further build on this, keeping in mind the endocannabinoid system dysfunction is also resulting in lower levels of our natural cannabinoids, which will promote anxiety anyway. So ultimately, we've established that cannabis slows gastric emptying, and any proemetic effects may be overridden by, may override the antiemetic effects. This is dose dependent, and our synthetics, again, they're full agonists, they're more likely to cause this. Genetics may play a role. We need more data, and keep in mind that THC is primarily metabolized by CYP2C9. Contaminants, not too much data suggesting they play a role, but this would include pesticides. Speaking specifically about the recent study published by Russo and colleagues, there was 28 patients with CHS that did genetic kits, and they were compared to 12 controls. These were the 5 mutations that were established as significant. So the first is the DRD2 receptor, the DRD2 gene, which codes for dopamine 2 receptors. Now, this will be associated with depression and anxiety. and have higher have effects of dopamine in general. Now we also see catechol O-methyltransferase gene being implicated here. This will result in dopamine excess from the loss of functioning cons. This can also lead to compulsive behaviors, substance abuse, gambling. Also keep in mind the potential link to cannabis use disorder here. It's not established, but keep that in the back of your head when you're dealing with these patients. Now, we're having two different genes potentially playing a role with dopamine here. And high amounts of dopamine are pro-emetic, and activation of dopamine receptors in the GI tract can slow gut motility as well, feeding more into that. The TRPV1 receptor will encode for TRPV1. I'm sorry, that gene will encode for TRPV1. Again, there was significance with CYP2C9. And there was also significance seen in the ATP binding cassette transporter, which namely affects cholesterol, but it has been implicated in cannabis dependency. Now that we've kind of set the stage for all the pathology, let's kind of talk about diagnosis and workup real fast. There are 4 criteria for establishing cyclic vomiting and cannabis hyperemesis syndromes listed here. So they're very similar across the board and often it's really hard to kind of discern which is which. The main distinguishing factor when you look at them is that in the context of cannabis hyperemesis syndrome, we see relief of vomiting after abstinence from cannabis. But with both of them, we see symptoms that must be present for 3 months with an onset of 6 months earlier. Now, supportive criteria for cyclic vomiting syndrome is history of migraine headaches, which it's thought to be a form of migraine. And the supportive criteria for pathological bathing, for cannabis hyperemesis syndrome is pathological bathing. However, it gets a little bit more tricky because patients with cyclic vomiting syndrome who are cannabis users pathologically bathe at higher rates. And a high proportion of individuals with cyclic vomiting syndromes also consume cannabis, and they both can be associated with migraines. Now, this is the largest case series by Symeto and colleagues. We have 98 patients. They included patients in the review if they had a long-term use of marijuana for greater than 2 years, had a history of recurrent vomiting, and any absence of major illness. If the patients, they couldn't agree on the diagnosis, consult was requested by gastroenterology to confirm. 67% of those patients had normal bowel habits. 62% of those had gastric scintigraphy performed. And of those, 46% had normal gastric emptying, whereas only 30% had delayed. The time of improvement varied from 1 to 3 months. Many reported relief from hot showers. Other supportive criteria that they established was having an age less than 50, being diaphoretic with 20%, and having normal bowel habits. But the majority of the symptoms recurred less than 2 months. And now in the systematic review, which was published a few years later by Sorensen and colleagues, they looked at different patient characteristics, and this included history of cannabis use, resolution of symptoms upon stopping cannabis, and compulsive hot baths with symptom relief. Now, they cited that there was a very low quality of evidence and that there was confliction with other data. They also noted that the criterion was inconsistently documented. So let's talk about the major criterion that was looked at. Now, there was 211 patients cited from these abstracts, but only 133 had raw data. And the main criterion that were cited is following. So cyclic vomiting accompanied by abdominal pain, symptom onset preceded by at least weekly cannabis use, temporary relief of symptoms with compulsive hot baths or showers, resolution of symptoms with cessation of cannabis use, onset of cannabis use in teenage years, and symptom onset in the 3rd decade of life. However, when we look at the raw data of those patients, out of the 133, 75.2% met 4 of those criteria, and 92% met at least 3. Let's continue to try and define this here. So as far as the supportive criteria that are inconsistent, the reliable return of symptoms within weeks of resuming cannabis use, normal bowel habits, weight loss, having a negative medical workup, or even have history of migraine. CHS may even be a variant of CVS, instigated by excessive cannabis use. The big distinctions here, though, is that patients with CHS will resolve following cannabis abstinence. And also, patients with CHS will have delayed gastric emptying, while patients with CVS have rapid gastric emptying. Now, I know I just said in the study by Simetto and colleagues that they cited a supportive criteria being delayed normal gastric emptying. Well, I would really recommend looking at the study cited below by Devono and Parker. It provides a really, really thorough review of cannabis hyperemesis syndrome. They cited 4 studies that supported this claim. Now let's talk about the phases. The first is going to be the prodromal phase, and this is where we see anxiety, severe nausea, a whole array of different autonomic symptoms such as sweating, flushing, increased thirst. And then these symptoms can be more severe in the morning, and it can last from months to years. And then following the prodromal phase, our first bout of emesis will result in entering the hyperemetic phase. This will follow debilitating abdominal pain, nausea, vomiting. This is where the patients will typically experience compulsive hot bathing or hot showers. And this will last until abstinence. In the recovery phase, vomiting and bathing behavior will stop, and the full recovery of symptoms will occur from days to months. Other clinical presentation characteristics, the hot showers may be taken up to 6 to 20 days. The patients, especially if they're admitted, they just want to sit in the shower. They also may experience burns from the heat associated with these hot bathing. Again, anxiety and panic attacks feeding into that pathology we talked about before. They're vomiting, so we're going to see electrolyte abnormalities and ketonuria, and maybe even a mild leukocytosis. As far as workup goes, social history is really important. What was the age of initiating cannabis use? How much per week do they use? How many grams of flour or eighths, or in some patients, quarters? How many cartridges did they go through? What were the percentages like? Where do they get the cartridge? Is it half-gram cartridges, or are they full-gram cartridges? Are they consuming the most potent of these forms, which is concentrates? How many grams of that are they using per week or day? And then behavioral factors associated with resolution of symptoms. Does consuming cannabis relieve your symptoms? Or does the hot showers relieve your symptoms? We want to also do a basic laboratory panel and exclude bowel perforation, cholangitis, pancreatitis, H. pylori. In terms of imaging, there's an expert consensus guideline from 2018 that recommends against this. However, other studies and reviews suggest doing an abdominal ultrasound and/or CT and an EGD at initial admission, and only to repeat if the clinical status changes. This is really important because we spend a lot of healthcare dollars here working with these patients, doing multiple scans, multiple EGDs, and even surgeries to determine the diagnosis. And that's just a waste of healthcare dollars. The expert consensus guideline also suggests a CHS assessment in healthy, young, non-diabetic patients presenting with previous diagnosis of gastroparesis. Now, interestingly, there was a survey-based study in which patient reported relief of gastroparesis symptoms with cannabis. It's just interesting to keep in mind here. If the patient denies cannabis use, but the suspicion is high, it's suggested to maybe consider a urine drug screen. Let's dive into treatment. Now, the expert consensus guidelines suggest the following with no treatment algorithm. They suggest topical capsaicin 3 times a day at 0.075% to the abdomen and back of arms. I do want to note that percentage is inconsistently used. The studies use different percentages of topical capsaicin. They cited effectiveness of Haldol, olanzapine, diphenhydramine, ondansetron, promethazine, metoclopramide. Benzodiazepines had mixed efficacy. They stated to avoid opioids and provide IV fluids. However, when you look at the other data, there's some confliction. So out of what there's alignment on, one, we don't have any treatment algorithm. Topical capsaicin, Haldol, benzos, avoiding opioids, and IV fluids are recommended. Whereas your more standard antiemetics like olanzapine, diphenhydramine, ondansetron, promethazine, and metoclopramide have not been shown to be effective. And let's talk about that. So ondansetron's not effective, and there is no evidence for effectiveness with second generation antipsychotics like olanzapine. Now, a retrospective chart review that cited diphenhydramine and metoclopramide as effective No other reviews mentioned this regimen, and that same chart review stated that ondansetron was effective as well. But this was refuted by the 2021 review by Reiner and colleagues. And then a 2020 systematic review by Zhu cited one case report with the combination of diphenhydramine, metoclopramide, and ondansetron, but this was ineffective. Ultimately, think about the quality of studies here. We don't have any prospective studies here or any randomized clinical trials. So it's really, really hard to use this evidence to navigate, especially if the studies are ultimately not as good as we would like them to be. We all are in agreement on don't give opioids, it may worsen gastrointestinal effects, constipation, reducing gastric motility. We want to incur abstinence for resolution of symptoms, and cannabis use disorder may complicate things. Now, I'm someone that really likes nice data. I like using evidence to make suggestions, but ultimately we need to remember that these individuals who are consuming cannabis for these prolonged periods of times, it's often a part of their social circles. It's often something they're very passionate about. It's something that they may be advocating for, and they may be part of the reason that us as healthcare professionals are really stepping into the forefront here too. So, and sometimes it's really hard not to look at that raw data because we need to lead with compassion for these patients, not necessarily comprehending what's going on with them. Now, capsaicin, it activates and then desensitizes TRPV1 receptors. We get analgesic and antiemetic effects via depletion and inhibition of substance P and neurokinin 1 in the spinal cord, vagus nerve, and medulla oblongata. Now, application sites include the abdomen as the main one, up to 3 times a day. We can do the back of the arms, chest, as well as the back. Now, the percentages used varied. So in the studies cited, they used 0.025, 0.75, and 0.1%. It's noted that higher dose is more effective. I do also want to note there's 8% patch, but this was not studied at all in the context of CHS. Now, there's no standardization that was used in these studies. So it's really hard to say how to appropriately provide this. We do want to wear nitrile gloves and avoid broken skin, face, eyes, mucosal surfaces, and do not cover with dressings. Side effects can include burning, itching, redness, and swelling, which can be worsened or instigated by higher percentages. If the patient experiences unwanted side effects, we can wash that off with skin. We can wash that off the skin with soap and water or alcohol. Now, the data on this is kind of questionable in terms of how much total antiemetics were reduced, as well as reduced length of hospital stay. Hot showers and baths, they also promote TRPV1 receptor activation and desensitization at temperatures above 109.4 degrees Fahrenheit. There's thought to be what's called this cutaneous seal syndrome. Now, what happens when we're activating these receptors? We're feeling heat, yes, but we're also promoting vasodilation. This vasodilation is going to alter splanchnic blood flow from the GI tract and move it more towards the surface, which is thought to help alleviate symptoms. And this is also a means to overcome the hypothermia caused from high-dose THC. Now, let's talk about the capsaicin and hot bathing mechanism of action, namely at the TRPV1 receptor. Now, with capsaicin specifically, it will cross the cell membrane and act at a transmembrane receptor. This will promote calcium entry. It will also go to the endoplasmic reticulum and promote release of calcium stores. In high enough concentrations, though, it promotes mitochondrial dysfunction by affecting the electron transport chain. Ultimately, high levels of calcium will then promote protease activation, cause cytoskeleton breakdown, and reduce activation of that nerve. And then we'll also see as a result, decreases in NK1, substance P, calcitonin gene-related peptide, and this all together will promote analgesic, antiemetic, and anticonvulsant activity. Let's talk about our antipsychotics. So our dopamine 2 receptors implicated in nausea development. Now, tying that back to our study on genetics by Russo and those 28 patients with CHS. dopamine may be implicated with those two mutations in the dopamine receptor as well as COMT. So that may be a reason why antipsychotics are effective, not the atypical set. So droperidol was cited as effective in a retrospective chart review, but that's also the same chart review that showed effectiveness of diphenhydramine and metoclopramide. Another retrospective chart review showed reduced length of stay and reduced number of antiemetics. Now, when you look at the studies, the dose ranges used were 0.625 to 2.5 milligrams given IV in a single dose. These are very low doses. In the context of Haldol, 5 milligrams given PO, IM, or IV initially, just once, or that was used as a loading dose followed by 2.5 to 5 milligrams up to 14 days in another study. Now, at these doses, it's super low, so we're not worried about QT prolongation occurring here. Benzos, so we're enhancing GABA activity, inhibiting neurotransmitters, and thereby reducing CB1 receptor activation and promoting reduction of nausea. In one study, lorazepam wasn't successful, but they switched the patient to clonazepam, titrated up from 0.25 to 0.5 HS, and that was shown to be effective. Lorazepam has been cited as being effective as 1 milligram IV single doses, or you can even give that as additional 1 milligram IV doses every 6 to 8 hours. Alprazolam was cited as effective, but I couldn't find any dosing on that regimen. We always want to provide supportive care. There was no specifics though on IV fluids given in the literature. Aprepitant may be an interesting place for further investigation because it's an NK1 antagonist. So we're going to inhibit NK1 and substance P in the dorsal root ganglion, which also may be effective in these patients. We have a prospective trial underway, which I'm excited about. So hopefully this gives us a little bit more information on capsaicin for the treatment of cannabis hyperemesis syndrome, but they're still recruiting as of now. Let's walk through our patient case as we kind of close this webinar. So we have Jeremy. He is a 31-year-old male. He has generalized anxiety disorder. Medications include buspirone, 50 milligrams BID, bupropion, 300 milligrams XL in the evening, zolpidem, 10 milligrams in the evening, but he doesn't like how this makes him feel, so he doesn't really use it, not adherent, not a problem. He has cannabis use. He uses it consistently for the last 3 years for anxiety and sleep, and he consumes all day and uses more at nighttime. This is very typical of the standard patient I see in the dispensary. So he comes to you as your cannabis clinician to kind of figure out what he could do to help with his anxiety and insomnia. And then while you're talking to him, you find through your discussion that most days of the week he's nauseous, but it improves after his morning shower and after he smokes half a gram of dry flower. When he talked to his PCP about the nausea symptoms, he was given esomeprazole, and this was not effective. Now, which of the following symptoms could signify CHS in Jeremy? Oh, wrong one. Oh, it didn't save. So just take a moment. If anyone wants to put answers in the chat, my poll did not save on this one. We see a bunch of C's. Yes, Marinol is considered to be synthetic, but it doesn't bind as potently to the receptor. C. Everyone's saying C. It looks like we have a consensus here. The answer is actually A and C. Remember, the CHS, we're going to see reduction of our natural cannabinoids and a whole host of other reasons that are going to aid in the patient clinical presentation. But yes, the main symptom that I would really be looking for is going to be frequent nausea that resolves after bathing and smoking. Next poll question. Let's get the right one up. Which of the following is the most appropriate recommendation? Select all that apply. Increase the amount of cannabis used in the morning and In PM, if symptoms worsen, then it's likely possible CHS. Increase the amount of cannabis used in the morning and evening. If symptoms improve, then it's unlikely CHS. Stop cannabis altogether and then reassess. And then, or stop cannabis altogether and reassess nausea after in the morning, after a month. There's a typo on the last one. So it's stop cannabis altogether and reassess nausea symptoms after a month. So select all that apply. Let's try this again. It's not giving me a hard time. Stop sharing. There we go. Is that working? Interesting. You see it? Technical difficulties. Nope. Oh, it's so interesting. Yeah, it's not working. Okay. Well, let's walk through it and all together. So what are the likely options here? So if anyone want to throw it in the group chat, what all the possible answers may apply to this patient? Are we going to increase? Is it going to be A, B, C, D? We have a C and D. We have a D. D. C and D. All the above. C, D. Pretty consistent, all the above. Yeah, technically it's all the above. There's no really wrong answer here. And we don't really have real guidelines on how to reassess our patients. Now, because symptoms can recur several months later, I would probably go with C and D, but then continue to follow up. But there's no wrong answer here. Good job, everyone. Last poll question. I'm gonna try this again. If it doesn't work, just let me know in the chat. Launching it. So which of the following recommendations could help improve symptoms? I didn't do anything differently, so I'm not sure why it's working, but I will take this. $13. See it a few more. We got 16. Let's take a look. So it appears to be between A and B. Now, the correct answer is going to be B. This is because bupropion, let's talk about the mechanism really briefly. So bupropion is typically used for depression, and it hits norepinephrine. So norepinephrine typically creates activation and can even worsen anxiety in some people. Also, another side effect to keep in mind in the context of his presentation is with bupropion, it can also cause agitation and worsen his anxiety. So that is why the answer is B. So we want to give that in the AM. And then that way you can help sleep better. Oh, I hit the wrong button. Moving on. In summary, the endocannabinoid system is a mechanism in which the body uses endogenous cannabinoids to maintain homeostasis. The pathology of CHS is complex, but it's not well understood. It may involve ECS dysfunction, HPA dysfunction, sympathetic nervous system dysfunction, and decreased gastric motility and genetics. We do not entirely understand the difference between CHS and CVS. Standard antiemetics don't work for either of these, and we don't have any established treatments or dosing exists for CHS besides stopping cannabis, but TRPV1 receptor modulation may be promising. I would like to close with talking about the legalization of cannabis. So it's really important for us as healthcare professionals, as this spreads throughout the country. We have more higher potency products than that was previously available. The potencies have increased from single-digit percentages to up to 20%. And we need to make sure the public is aware of this potential syndrome. And also other healthcare professionals. We need to educate others within our team so we can reduce healthcare resource utilization. And that way, the better we understand cannabis and the effectiveness of it and how it's therapeutic, the better we can really establish relationships with patients, reduce stigma, and increase trust. The number of times I've come into work at the dispensary and patients don't want to talk to me, and I typically have to get my patient consultants or bud tenders to really pull them in. I'm really blessed with a wonderful team, so we work very well together and help each other out. So I'm usually able to have conversations, but I'm often met with a lot of resistance because they don't trust healthcare professionals to take them seriously. And lastly, empathy first. We put an emphasis of comprehension and understanding others in our society. And I think we need to switch that around. We need to lead with compassion. These patients who develop CHS are losing social connections. They're losing a cause they believe in. It's going to be hard for them to be around those that they used to be with, especially if consuming the cannabis is going to trigger this for them. And it's really kind of sad when we look at it from that perspective. And being one, empathetic with them and increasing trust with them may help them get through it, and connecting with them with appropriate resources. Here are my references. I do want to quickly go to my appendix because I did see a question about Marinol. Now, Marinol, I just want to say that Marinol, 1 milligram of Marinol is equivalent to 1 milligram of THC, whereas Nabalone, on the other hand, it's 1 milligram is associated with, I believe, 10 milligrams. 1 milligram of Nabalone is equal to 10 milligrams of THC. So the Nabalone is actually more potent in terms of converting over. I just saw that question. I just wanted to briefly address it. And let me just go back. And with that, I would like to open it up to questions. Krista.
Oh, sorry, I was just doing a clapping emoji.
Oh, thank you.
It was very well done.
Thank you very much, everyone. I hope this was informative. Message. Thank you, Seema. I hope you guys have a wonderful day.
Bye. Thank you.
See ya.
Good job, Mike.
Thank you. I'm actually not sharing the slides, but the presentation will be available on ICPH website for you to rewatch. Any questions? All right. Everyone have a great day. Thank you, Lex. Thank you. Enjoy the rest of your weekend.